Eric Higginbotham. I work with Robert. I'm the medical director at Dell. Let's see, I was there when it opened, when we were seeing around 40,000, and now we're up to upwards around 80,000 visits a year, depending on how busy flu season is. And given the number of meetings I've had over the last 5 days about the volume that we've seen, I can tell you that flu is not going away, despite what everyone will tell you. We had on Monday 325 kids seen in 24 hours in our department. And regretfully, that wasn't one of the days that I usually do meetings. I was actually out there, and out there 3 hours after I was supposed to be home. The other thing, just real quick while I have everybody, the other thing that's happening right now that everyone should be aware of is measles. We've had, I think there's 5 cases now in Harris County, and then there's a confirmed case as of this morning in Round Rock. And it tends to be either unimmunized or partially immunized, so people that's only got a single vaccine. And then the reason why I think it's something that everyone needs to know about is when you look at Harris County and the number of unvaccinated or partially vaccinated people in that county, they rate, I think they're about 10th in the nation. And then when you look at Travis County and the surrounding counties there, our unvaccinated rate, I think we're about number 3 in the country. So there's a fertile population that once it takes hold, it's going to kind of take off. So this is my thank you slide to Dr. Verzetti. Down at the bottom is why I possibly may be talking twice, which is some of the slides in this talk are going to be some of the slides that you saw in his shock talk as I talk about resuscitation. So we'll get through this. We'll see where we're at with time. I have another talk on burn and fluid resuscitation in burn, and that's specific to kids. And so if we get through this part with time to spare, and there's a willingness of you guys to listen to me ramble on like I tend to in this kind of monotone voice, then I'll continue to go through it with y'all. So I used to work at BRAC. And then thank you, Robert. Your sense of humor is always helpful. I love the fact that he was in the Stella Artois commercial as well during the Super Bowl. All right, so we're going to talk about, like I said, some of this is going to be redundant, and I apologize. But we're going to talk about shock, some of the recognition stuff that Robert went over. I'll try to go over briefly because I don't want to bore you guys. Then we're going to talk about ABCs and fluid resuscitation in infants. All right. Yeah, this is like the Monty Python t-shirt that you, so we're going to talk about the clinical recognition, how no single vital sign. Robert touched on how children tend to be extremely resilient. So rather than sort of a gradual decompensation like you may see in adults, you tend to have a precipitous fall off in mental status and vital signs when they hit that key point. Cardiogenic, neurogenic, obstructive. Robert talked about the child that had the cardiac arrest from what we think was probably myocarditis from influenza, and went on ECMO. And so, I think I will probably never see that again. But if anybody watched the news last night, I think it was on KVUE and on Fox, him actually getting to leave the hospital, which was really, really amazing. The other thing about that kid is he stole one of my Nerf guns. So my wife does pediatric rehab, and she brought some stuff up there. So now I have to track him down to get my Nerf gun back for my kids. So the number one cause of shock or decompensation and need of fluid resuscitation is going to be hemorrhagic. All right. I won't go through this. Robert talked about this briefly, but compensated, uncompensated, and irreversible. And for all intents and purposes, that myocarditis kid, I would have placed him in an irreversible category. When you talk about having a willingness to continue to learn and accept new stuff, one of the things I've had to come to grips with myself was I was present in the ED, didn't take care of the kid. The attending taking care of that child was a relatively young attending. and it had reached the point where I felt I needed to step in, and if it had continued a little bit longer, sort of coach him up on how to end that resuscitation, even though that's difficult in kids. And then one of the other attendings described it as sort of like a group of angels descended, which was our new ECMO team, put him on the circuit in the trauma bay, and like I said, the kid walks home. That is amazing. I think you're going to see more and more in the ED, at least at Dell, if it's a witnessed arrest, us using that echo circuit as a bridge to getting those kids out of bad situations. All right, so we talk about 3 types: mild, moderate, and severe. Usually we're going to be seeing mild and moderate, and you're going to be able to tell the severe kids. So we were talking about kids screaming and yelling, and that's not the kid that worries me. So I can walk through the ED, and if I'm walking past 21 or 22 and I hear somebody yelling or screaming or asking for morphine, I know we're good. If I walk past the trauma bay and I see some kid laying on the gurney who's not moving, that's when I get worried, because I know that I'm either in an encephalopathic kind of situation, or I'm in a place where we're dealing with greater than 45% blood loss and the child is not responsive like they need to be. All right, this is that decompensation that we talked about. This isn't one of my kids. This is about how mine behave for the most part. All right, he showed this one, and I added something here. So you're not going to get out of any emergency medicine doc talking to you, or any kind of textbook, or anything approaching any problem without somebody putting up a slide that has ABC written on it. So let's just check the box. What I really put this slide up here for is the Krampus picture that Robert talked about, which in my house, I think most people have an elf on the shelf, right? Right? I don't, because that doesn't work with my kids. What works is I bought this one, and he shows up every Christmas when somebody isn't listening to me, and that's my Krampus in the corner. And if you pay enough attention to this, you'll see there's a little kid in his little basket on his back. That gets results, by the way, if anybody needs a little bit of parenting tip. I think I bought it off, this is going to be horrible, I think I got it off of Etsy or something like that. So don't tell anybody I go there and buy stuff. Okay, so the ABCs. Airway, we won't go through this in the disability. Circulation, and so the ability to give fluid rapidly is what we need. That's going to be the largest IV that you can get in the largest vein. And so for kids, that tends to be antecubital or posterior, the dorsum of the hand. And then if you can't, you can go through and use alternatives. And like Robert was saying, this device here has really moved us away from having to have a bunch of other techniques in our armamentarium to get access. And so we used to do cut downs, or in the trauma bay, we would put a pediatric cordis, which is just sort of a large bore IV in the groin. I haven't put a cordis or a central line in the trauma bay now, probably going on 8 years. And then in children, proximal tibia, but a lot of us are now going to distal humerus because, and this is not science, this is just sort of what some of us feel, is that it anchors better in that distal humerus than it does in the tibia. This one, just as once again as a practical matter, the little 15 millimeter, I don't even know why they make it much anymore. Even in infants, I find it to be too short a lot of times, and I've had people who say they've attempted IOs, or fellows who've attempted IOs, and they've used this pink needle, and they've never reached the table of the proximal tibia. So generally, it's going to be this 25 for kids and that 45 for adults. And then this part, Robert, did you go over this? The key here is that when we talk about that precipitative drop, don't wait until you see those telltale signs of decreased mental status, thready pulse, or hypotension. At that point, you know you've fallen down into that valley, And so you want to sort of arrest that progression early and then intervene and then get that blood or get the circulating volume back up. Okay, this is a no-brainer, right? You're not going to put an interosseous needle in that, and you're not going to put it through any kind of burn or infection. The biggest complication you're going to get is osteomyelitis, and that's about 1% of the kids. So we talked about the different classes. One of the things that helps us a lot in the trauma bay and allows us to know possibly where we're at in that continuum of shock, or where we need to start thinking about packed red blood cells or massive transfusion, is going to be how much fluid's given in the field. So the ability for us to know from you guys how much was given, and then as we talked about earlier, are you a transient responder or a non-responder, helps us. So was it a lot of fluid in the field and the kid still comes in and isn't thinking right and has a thoracic pulse and is tachycardic and hypotensive, then that's the kid that I'm probably going to initiate blood in the resuscitative bay quicker, and I'm going to be talking to the blood bank about doing what's called a massive transfusion protocol. And so we activate that about once every 3 months. And that is a program where we no longer have to ask the blood bank for product. They bring us 1 part PRBCs, 1 part platelets, 1 part FFP, and they continue to give us that until we tell them to stop. And we get into that kind of scenario when we see non-responders, or we anticipate, given the severity of the illness, that we're going to need to transfuse them their whole blood volume in a 24-hour period. Robert talked about that briefly. So we talked about responders, transient responders, and non-responders. In the rigs in Williamson County, is there anything that's equivalent to a rapid transfuser, or like a Belmont at all? Yeah, pressure bag. Okay. So this, I think, is the Belmont. Yeah. So we have one of those, and what that allows us to do is, if you just say pick an adult-sized patient, we can give an entire pack of RBCs in about 120 seconds. So now that doesn't count the time that people who are challenged with devices like myself sometimes have to figure out how to set it up. So what we've done now is, in order to keep that skill set going, is we actually prime this with normal saline when we have traumas coming in, just so people don't forget the muscle memory of how to set this up. I didn't mean to do that. So this is what I just talked about in terms of massive transfusion protocol. And this really comes out of our conflicts in Afghanistan and Iraq about what was most successful in keeping people perfused and increasing survivability with some of these catastrophic illnesses. Now, a lot of the field hospitals did not use a massive transfusion protocol. They actually used fresh blood. And so someone would come in, there would be a call out that we're going to have several casualties coming, and then people would donate fresh blood in real time. And they used that as their means of resuscitating these field injuries. This is sort of an approximation, or this is the best that we can do with the products that we have available in a hospital right now. So TXA, this is another game changer that came out of our conflicts overseas. And what this does is you have plasminogen, plasmin, and then plasmin will cut fibrin. Fibrin is what makes your clots. And so TXA blocks this step, and what it is a clot stabilizer. And that in and of itself is important. I think the other side of the coin is it has almost no side effects that we've identified that are deleterious to kids or adults. So there's a lot of studies that say it helps, and on the converse, that makes a lot of us very comfortable with it, is there's really no study to say it has some bad outcomes. All right, so it's sort of like if it's not going to hurt you and it may help, then we're going to give it. In kids, though, this has not been well studied. There's a big group of pediatric hospitals called the PCARN group, which is a Pediatric Emergency Care Research Network. They're the guys that came out with some of the guidelines around closed head injury, where if you don't lose consciousness, you're not throwing up, you probably don't need a CT. And we've been able to markedly reduce our CT use. They're looking at TXA in pediatric, both blunt and penetrating trauma, to come up with definitive guidelines about whether or not this is safe in kids, and if it is, what is the appropriate way to give it. Right now, we tend to use 15 cc's per kilo, and then about a 2 milligram per kilogram infusion. And I don't think this has been incorporated yet into our massive transfusion policy, but I think it's going to be soon. I think a lot of people, once they found out that there's actually an active network that's sort of systematically looking at this, they're going to wait for those results to come out. And you couldn't get any cuter than the woman that discovered it, right? Right, cardiogenic shock, you're going to approach it the same way, except in this case, and in some of these slides I'll touch off of what we talked about earlier. So if you have hemorrhagic shock, the situation there is always going to be volume replacement, right? It's either going to be crystalloid or blood. But when you get into some of the other types of shock, I'll just mention briefly, that's not always going to be the solution, right? So if we see something like this when we do our portable x-ray, some of you guys come in and you know we will the ultrasound over now when we do an expanded fast exam where we're looking at the heart. Then any amount of fluid isn't going to fix a pump problem. And so if you have this kind of problem where you have pump impairment, then you're going to need to do, you're going to need to either aspirate that, or you're going to need to call your cardiothoracic surgeons to come in and put a window in. Or if it's penetrating trauma, then they need to get in there and fix the hole. All right. Same sort of thing when you talk about tension pneumothorax. You can give, and I've seen cases where people get into trouble because they get fixated on the hemorrhagic loss and get fixated on a volume issue, and it's not a volume issue at all. So just like the tamponade, no amount of fluid is going to fix a tension pneumothorax. So you could get down, I've seen people go as far into the 60 cc's per kilo. They're talking about setting up the Belmont that we talked about. They want to give blood, or they want to give blood products, and it's not a blood product issue. Someone listens to the chest, if they're good, and hears this and then decompresses it at that time, or they wait for that portable chest to come back and they see it incidentally. All right. Neurogenic shock. I hate that picture at the same time. It's horrible. So this is another one where you can get confused, and within the same sort of traumatic injury, you can see multiple types. In the same sort of traumatic injury, it's a shock. So, and this is probably the least common that we see, but that'll be a spinal cord injury. You lose all peripheral tone, and so they'll come in and they'll look like a massive exsanguination, right? Or maybe they have some blood loss, but you don't think it fits into any of those categories of mild, moderate, or severe. And you're giving crystalloid, you're giving some blood products, and you're still not getting something back at that point, all right? And so that's when you think that maybe this is neurogenic shock. You've likely ran your way through the fluid resuscitation, and what you need to do there is give more peripheral tone back to them. And so in the ED, we'll use something like norepi, or we'll use epi in order to get that peripheral tone. So the thing that I think that's worth mentioning is making sure we have good access, and then making sure that we give volume resuscitation before you get to the point of deterioration. And no one's ever going to fault you for that. Right now, I mentioned this earlier, in Travis County, they're beginning to have discussions about actually having blood on some of the rigs. The problem with that, though, is twofold. One, it's cost, and those blood products are probably going to expire before you ever get to an accident where it's going to be useful. And then two is just the scarcity of those blood products. And so we've had very limited, I wouldn't call them a mass casualty event, but we've had the minivan full of kids where it blew out one tire. And we stressed our system in terms of blood bank availability just with 4 kids at one time. So I can only imagine that if we're trying to have every truck have 2 units of packed RBCs, I don't know if the system can sustain that.